E uma outra questão importante, Manon, é em relação à associação de quimioembolização com terapia sistêmica. Você acha que a gente já tem dados, já é uma questão que faz parte da sua prática clínica ou ainda não?
Well, we have the positive result of the 2 phase 3 trials last year, which were really nice, with really nice data regarding PFS and also regarding response. But for the moment, in the French guideline that we wrote this year, we decided not to propose this because we think that we are waiting a bit for longer result with the survival. And also we were a bit worried about the side effects and the toxicity because in both of the trial we observed more than 50% of grade 3, 4, 5 advanced event, and this was quite a lot. So for the moment we are not doing this in clinical practice, but for some patients, especially younger one, we want to downstage to push them till liver transplant. This is something we can do, and I did this for some of my patients and it worked really well. But for the other patients, we are more taste, and if it's not working, systemic therapy like sequential, but not altogether for the moment.
Vou finalizar então com 2 situações práticas do dia a dia. Paciente Child-Pugh-B e paciente com invasão vascular VP4. Uso da imunoterapia, existe algum esquema que seja melhor, algum que seja contraindicado? Como é que você faz?
Well, we do treat Child-Pugh-B patients in France, and we have quite a nice results. We have like a large cohort, multicentric prospective cohort, which is called cohort Chief. And so we updated data this year, and in this cohort we have 20% of Child-Pugh-B, which is quite impressive, quite large. And the data are quite nice because we have like 10 months of median overall survival. So this is not so bad. So we are doing it. After, how to choose? Well, I think Child-Pugh-B can be different Child-Pugh-B. You can be as we discussed this morning, it can be on albumin or bilirubin and ascites. And we are a bit more careful with the patient with high bilirubin and also ascites. But what we are doing in my center is patient with Child-Pugh-B and with a bit of ascites and low albumin. We are proposing, albumin perfusion at each infusion of immunotherapy, like it was done, in the ANSWER trial for patients with cirrhosis with a bit of ascites that show that after long follow-up, if you propose albumin, you will have an increase in survival and less ascites occurrence. And so we are doing this for the patient, and it's quite well because we showed that the amount of ascites expansion is lower, and also the quality of life seems better. So we are doing this. We treat Child-Pugh-B patients, and in my center we add albumin. So we are also treating patients with VP4. So first of all, maybe I will say that in this patient, well, in all HCC patients, but especially this one, is really important to screen for portal hypertension because we know that this is a complication and can lead to varicose bleeding. So this is really important, and in France it's recommended to perform endoscopy to all patients. HCC patients. No BAV, criteria because we demonstrated that it's not powerful enough. And we propose beta blockers in all patients, even the one with small varices, because also we observe that even if you have small varices with HCC treatment, this can lead to an increase in the portal hypertension and the site of the varices, so we treat everyone. And so for VP4, for the moment, so in France we have access to atezobev and durvalumab only, and so we don't have so many data. We've got the data from the subgroup analysis of EMBRAVE 150, which show also a better survival in VP4 patient compared to sorafenib. But unfortunately, we don't have this for Himalaya because these patients were not included. However, we are treating our VP4 patient with both, either atezobev or durvalumab, no limitation. How do we choose? It will be finally regarding the potential contraindication to bevacizumab, so mostly history of variceal bleeding, for example, or all the cardiovascular contraindications. But for the moment, there is no one better than the other. In France, it's like we can do both, and it will be mostly regarding the contraindication to bevacizumab.
Temos que individualizar. Muito obrigada, doutora Manon.
Thank you very much, Cássia.